Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Welcome to Doc Discussions. This is Jason Edwards, and I'm here with my good friend, Dr. Neil Ettinger. Neil, how you doing today?
I'm doing well, Jason.
Good to see you, sir. Neil, you're a pulmonologist. Is that correct?
That's correct.
And so tell me a little bit about yourself. Where are you from originally?
I grew up in Miami, Florida.
Really?
Yeah.
I've known you for a while. I never
knew that.
Yeah.
Did you? You never asked me.
Yeah. So Miami's an interesting place.
It was far more interesting in, the 1960s and 70s when it was a new city and it was just being born, but it's gotten pretty busy and pretty different than when I grew up there.
Yeah, I was there a few years ago. One of the things I recognized, it was a third Hispanic, a third African American, and about a third Caucasian or white. Was the demographics, have they changed over the years?
I don't know if that's true or not. I mean, I think it used to be half, white, half Hispanic, with a small sliver of African American in there. But
yeah.
It may have changed over the years for sure.
Yeah, mostly Cuban, right?
Right.
Yeah. And so, yeah, great city for sure. And then where did you go for undergrad from Miami?
I went to Vanderbilt University.
Very good.
So I was there from 75 through 79.
So you were a Commodore, huh?
I was a Commodore,
yeah.
But it took a while to adapt to the idea that I was in that deep South, place, because Miami was never felt deep South.
Sure.
But Vanderbilt certainly did.
Yeah, Miami, it feels like an international city, really.
It does.
Yeah.
It does.
And then from Vanderbilt?
WashU Med School.
Very good. Very good. And then you stayed there for residency as well?
Stayed there for residency, and then I took a year off and went to England for a year. Did some critical care at MOBAP for 6 months. And then 6 months in London, England, where I did some research on bone marrow transplant patients with lung complications.
How about that?
Yeah.
And which hospital was that?
The Royal Marsden Hospital in London, and then the Brompton Chest Hospital in London.
Yeah. And was their healthcare system, was it different than ours?
Much different, and it's still the same today. I mean, it's a national health system, so long waiting lists for elective procedures.
Yeah. And you may know this, Chris Cronin's grandfather wrote a book, Jack Cronin, and they say that is kind of the impetus for starting the NHS.
Oh, really?
Yeah. And the name of the book eludes me at the time. But he kind of wrote a book about how their healthcare system just wasn't working well. And it kind of became a bestseller. And they wrote multiple movie scripts after that.
Well, in England, they have the Harley Street doctors, which are the equivalent to private practice doctors if you can afford them or have insurance for that.
Okay.
Otherwise, everybody is in the national health system. And I don't think that's changed any.
Okay. Yeah, and there's some pluses and minuses to the socialized healthcare for sure. And that's a topic for a whole other deal. Mm-hmm. So you're now pulmonary. So after you do your internal medicine residency, then you do a pulm crit care residency or fellowship?
So at the time, critical care was not its own specialty.
Okay.
I'm that old.
Okay.
So, it was pulmonary, and then you did, you came out with your, certificate in pulmonary and critical care. Later on, critical care became its own specialty, and so you don't automatically get pulmonary and critical care these days. These days, you need to do two separate fellowships or an extra year in your pulmonary fellowship for critical care.
Okay, I always thought it was the same thing wrapped up in, but they're two separate specialties now.
They are.
Okay, that makes sense. I mean,
you can get certified in pulmonary and critical care with the extra dedicated year to critical care.
Yeah. And it makes sense they would go hand in hand, obviously, because a lot of the patients are on ventilators and things like that.
Right. So when I was in training, in the 83 to 86 was my medicine residency. I took that year off in 87. So 87 through 89, at that time, critical care started to become its own specialty, and intensive care units started to take off as dedicated facilities. So critical care didn't always have the kind of sense of an ICU that we know today, that evolved too.
Yeah. And you have some are open ICUs and some are closed.
That's correct. Yeah.
And so, but I think the trend is moving more towards a closed ICU that's just managed by an intensivist.
The intensivist, correct.
Yeah. Which seems like a good way to go.
Maybe.
It depends on where you're at.
It depends on, there is a role for specialists, of course, in a closed ICU. So as long as the patients get the best care and there's interchange of ideas, it's that interchange of ideas that makes a difference between a spectacular ICU and the average ICU.
Yeah.
Where when you have difficult cases, you have, people with different, approaches to treatment and diagnosis, all of them collaborating on the same patient. Yeah,
I would think any ICU should have a strong relationship with their pulmonologist, whether they're managing, quote unquote, managing the patient.
And I think for the most part we do.
Yeah.
I think, what we don't need to do is duplicate services.
Yeah. Yeah. And especially these days with, most hospitals operate on a very tight margin. We need to be efficient, but maximally effective as well. So in your practice, of course, you and I interact a fair amount with patients who have lung cancer.
Correct.
What percentage of your practice is, malignancy versus non-malignant pulm issues?
So, I would say malignancy is probably 10 to 15% of my practice. A lot of the rest of it is chronic interstitial lung disease, since that's an area that I've specialized in.
Yeah.
And so I see a lot of patients with interstitial lung disease, and we're a pulmonary fibrosis foundation care center here. So we are kind of known for our expertise in that. So I spend maybe half my time. We have a clinical research unit called the Lung Research Center that's connected to our practice, physically. And we put a lot of patients in clinical trials for new drugs for treatment of interstitial lung disease.
What causes interstitial lung disease?
Well, there's the group of interstitial lung diseases of known causes, and then the unknown causes. And so the known causes might be autoimmune disorders or occupational lung exposures, drug-induced lung disease, whereas the unknowns might be the most common being idiopathic pulmonary fibrosis. The idiopathic means we don't know what causes it, but the idiopathic, is probably the largest group. And so for most people, we don't know what triggers the development of pulmonary fibrosis. What we do know is it's a disease of aging.
Okay.
That you don't see this in people who are in their 40s or 30s. You see this in people who are in their 60s and 70s and 80s.
What do they think causes it? Are there any contenders or hypotheses?
Some injury occurs, at the cellular level that elicits an abnormal response of wound healing. So instead of healing completely so that it's indistinguishable, you have this constant drive to form more scar tissue.
Okay.
Sort of like if you are a keloid former and you cut yourself, ordinary non-keloid former people would heal.
Yeah.
And you might not even be able to see the cut down the road, but in keloid formers, you get heaped up scar tissue that develops.
Yeah.
So what triggers that exuberant development of scar tissue? Well, you see that in the lung, in a patchwork type quilt in the lung tissue where you got normal areas of lung next to scarred up areas of lung.
I treat patients who have keloids after surgery. And of course with the keloid, it's an overactivity of the fibroblast, and mostly in African Americans, but not exclusively. And then you can have excess scar tissue formation on the palm, which is Dupuytren's contracture.
Mm-hmm.
And a similar process. And then in the penis, you can have it, which causes Peyronie's disease. But it's probably, I would assume in the lung, it's probably a little bit more complex than those processes.
And it's more microscopic, and it's but the lung ultimately becomes, stiff and small and incapable of exchanging gas.
Yeah.
You can't get, oxygen into the system, and you can't get carbon dioxide out at the end of the, when all is said and done at the end.
Yeah. Yeah. That delicate tissue that exchanges the oxygen into the blood needs to be thin. And if it has scar tissue, it's just not going to.
Exactly.
Yeah. That's interesting. I recently bought this device that I put in my house that measures particulate matter. It has like particulate matter 2.5, 5, and 10. I think it's microns, but I'm not sure. And then it measures like HCHO, which is formaldehyde.
You want me to come over and help you clean out your ducts?
Well, it actually turned out to be pretty good. The one thing that was high was formaldehyde.
Oh, really?
So they think that can come from furniture and things like that. So I had to get this filter. It's like got like 26 pounds of carbon in it, a special type of carbon to like filter it down.
Filter the whole house, air conditioning.
Yeah. And so, but it just made me kind of cognizant that like, you've got to kind of be paying attention to
It sounds expensive.
what you're breathing. Yeah. It wasn't cheap, but it if I'm breathing every day, I feel like I should, there's dumber things to spend your money on. And
so we're much safer here in the hospital, I take it.
Yeah. I think an older building probably just has cleaner indoor air, because the off-gassing of things, whether it's the materials used to make a house or the carpet, is less because they've kind of off-gassed over time. And then, of course, outdoors is typically the air is a lot cleaner than indoors. Yeah. I think that's right. Does that sound right?
Don't know.
Yeah. Yeah. I guess it depends on where you're at. To me, it seems like St. Louis is very high in allergens because the flora and fauna. Does that play into your practice? People have allergens and asthma?
It does. A lot of allergists see the easy to treat asthmatics and the more difficult ones, but it seems the pulmonologist doesn't see the asthmatics quite as much. Okay. Unless the way the patient is presenting is misleading and you finally figure out that what they actually have is asthma.
Got you.
I think the Midwest and in the Midwest, St. Louis is probably at the top of the list for allergy, for difficult allergy cities. Yeah. And I think it's always been that way.
Is that a function of our rivers meeting here and there's a lot of different flora and fauna?
Don't know. Yeah. Don't know, but I suspect that it does have to do with the plants that are found here and the temperature here and what spores can live here in the soil and that sort of thing.
And and speaking of things in the soil, you and I look at a lot of CT scans and see a lot of benign nodules. Right. And it seems like this is kind of fertile ground for benign nodules in the lung. Is that the fungus that causes that, or?
Well, as you know, histoplasmosis kind of lives in the soil here, and it doesn't take much disturbance of the earth to get the spores, circulating, and it is easy to inhale. And when you inhale histo, the body reacts to it. It turns on its reaction and kills it where it sits, and the nodule is the evidence of the battle. Yeah. And it may go on to calcify. Typically, will go on to calcify.
Which is a good sign.
Yeah,
you'd rather see a calcified nodule.
I don't think you've radiated too many calcified nodules.
I don't think so. And they don't do much if you do, I would presume. I see patients who have ocular melanoma, and a lot of times we'll get the staging scans for them, and I always try to kind of give them a heads up. Plenty of people will have nodules in their lungs in St. Louis that are not cancer. Right. And so, and now patients can read their CT scan results before you can talk to them.
And that's an issue.
It is a big issue.
Right.
And it causes a ton of anxiety. And I think it's a federal law now.
It is.
And so I think it's probably, in my opinion, done more harm than good. Do you have any thoughts on that?
I mean, I think it, in some ways, it does take the pressure off that the patient can be just as informed as you are.
For sure.
I think while I don't mind them seeing results and dealing with the anxiety that produces, because that's a choice that they've made, at least they have the option to make that choice. Yeah. I think what I do mind is their being able to read notes that might have very candid comments because you're trying to be accurate and communicate to all the other doctors. And I think sometimes patients may find the ability to read their own notes disturbing, or upsetting.
Yeah. Yeah, for sure. And there's no doubt about it. It's going to modify the behavior of the doctor. Like to give the listener an example, if somebody's very obese, that can play into their breathing. It can it can play into a lot of different health issues, but I'm probably going to be less inclined to say a patient is very obese in their note if I know they're reading their note, and maybe that's bad on me, or I'm just saying the doctor, the generic doctor would be less inclined to say something that's true, but maybe reflects poorly on the patient and is,
well,
kind
a
of
good
less
example for me would be somebody who complains of shortness of breath, and you've done a complete workup, and in the end, you suspect it may be due to obesity or deconditioning, or it may be related to anxiety or stress.
Yeah.
But you cannot reach that conclusion without having done the work to be sure it's not the heart or not the lungs. People don't sometimes feel dismissed when they're asked about anxiety or stress or depression. But it's a necessary question when you have symptoms of shortness of breath that aren't obviously explained by something else.
Yeah.
Because it is a true bona fide cause of these symptoms.
No doubt about it.
Same thing with obesity and deconditioning. It is sometimes difficult to say, well, you're overweight, you're out of shape, you're deconditioned, and the heart's good, the lungs are good, everything we've checked is good. But sometimes people feel dismissed by that, by reaching that conclusion.
Yeah.
So reading it in the absence of being able to discuss it at that moment with the doctor can be, I think, hard to handle sometimes.
Yeah, and kind of in both situations, there's a lack of context and nuance that
Right.
you could, in a face-to-face conversation, you can see somebody's not trying to hurt your feelings. They're just trying to be as honest and as accurate as
Right.
possible. And yeah, for sure. It's made medicine and the practice of medicine, which is already complex, kind of more complex.
True.
And so a lot of the patients that I end up seeing ultimately for lung cancer have gone through our lung screening CT program, and I think we do a really good job of that. Lola Brand is
she
awesome.
does a great job.
One of our nurses who helps with that, and there's some pluses and minuses of every screening program. You can have some false positives, and can you talk a little bit about the screening program and kind of what patients qualify for that? And
well, patients from like age 55 through 77 qualify. If they have stopped, they can still be smokers. If they've quit smoking, it can't be for more than 15 years. And if they've smoked up to, I guess, 20 or 30 pack years, I can't remember the precise criteria there. And if they meet those criteria, they can then enter into an annual low-dose CAT scan screening program. And low-dose radiation is what we're talking about.
Yeah.
And because by the time you see an abnormality on a chest X-ray, most of the time that may be more than a stage 1 cancer.
Yeah.
And metastases are common when you're waiting to see something pop up on a film. So chest X-rays have never really saved any lives, but CAT scans have been shown to save a significant number of lives by finding cancers when they're more treatable. When you're annually screening somebody, you have a very good chance of getting something when it's an early stage cancer.
And one of the lung cancer, more than other more common cancers like breast, prostate, and even colon cancer, it can really go from stage 1 to stage 4 pretty quickly.
It does.
And the outcomes difference between a stage 1 and a stage 4 cancer are just night and day. And so it's not surprising. I think that the survival benefit that came from this trial was stronger than the other screening programs. And it's kind of not surprising for that reason. But it's the minority of people who actually would qualify for it who actually get screened. Is that right?
Say that again. The minority of people.
Yeah, the minority. So the amount of people out there who are eligible to undergo screening for lung cancer,
is much larger than those that actually get screened.
Yeah.
Yes.
It's just very few out of.
Well, it helps to have. That's why it's helpful to have a coherent program.
Yeah.
But recognizing that the new patient that you're seeing in front of you, who has an internist and a endocrinologist and a rheumatologist, and who's going to remember to order the lung cancer screening? Nothing is made automatic. Somebody has to remember to order it.
Yeah.
Once you're in a program, and most centers or in hospitals have a program rather than just randomly offer a CAT scan. But once you are in a program, then annually someone's going to be reaching out to you or notice that you didn't show up or didn't have a screen.
Yeah.
And so I think having a real bona fide program is key.
No doubt about it.
Because all those people that are not being reached are sometimes falling through the cracks in their own physician's office and in their pulmonologist's office.
Yeah. And I feel very fortunate to have a great program here. The number I have is that only about 6% of eligible U.S. adults get screened, which is just,
think of how many lives we could save.
It leaves a lot of room for improvement.
If it was 80 or 90%.
Oh, yeah, for sure. And it's the newest screening program, too. I mean, mammograms and colonoscopies have been out, and prostate PSA checks have been out there for a long time. And the lung cancer screening is relatively new. I think it's maybe 2010 or something like that the trial was actually published. But I think, if we're looking to save lives, that's certainly an area of opportunity. And if a listener's interested, you can call St. Luke's and get right into the program. Usually, if you meet the criteria, it's not an issue at all. And it's very well run. And we've saved a lot of lives, through our hospital with these patients. Right. If it's a stage 1 lung cancer, the patients are typically seen by Ryan Reedy or Jeremy Leidenfrost, and they have a lobectomy or a wedge resection, or seen by me, and we treat them with a short course of radiation. Right. So, of course, the majority of patients who have lung cancer, it comes from tobacco, cigarette use. But there are some patients who do have a lung cancer that's not from smoking. Is that right?
That is correct.
And do they know what causes that?
Well, there may be, other things like radon gas in a household.
Yeah.
It might be, chemicals in the home environment or in the food supply, so there's lots of angles by which, people can develop lung cancer. Across the world, it's, indoor cooking, when you're burning charcoal or you're burning wood, to cook and to eat, people get lung cancers and emphysema from those exposures.
Yeah.
There's, absolutely, a role for non-cigarette, non-tobacco causes of lung cancer, although, tobacco is the first thing we think of when we think of lung cancer.
Yeah. If I recall, it was like 95% are from cigarettes. Now, sometimes, and especially in Missouri, radon is a real issue. And that's why if you buy a house, you have to, see if you need a mitigation system in your basement. And we actually use radium to treat cancer, radium 226 and radium 223. And radon's just an off product of that. And so it can, it's radioactive.
Right.
So it's a big deal. And then, sometimes when patients, especially if they're a non-smoker, have a lung cancer, they have what they call a driver mutation, as you know.
Mm-hmm.
And there's some targeted chemotherapy that's just a pill that you take, and patients can do really well, even if they have metastatic cancer. And so,
so what you're saying is that that in non-smokers who get lung cancer, they may be more amenable to some of the new targeted therapies that we have.
Yeah, absolutely.
That many smoking-related lung cancer patients are not. They do not benefit.
Yeah, it just kind of happens, to be like that, and so they're out. So the outcome of somebody with who's a non-smoker with a lung cancer compared to a smoker is better. And it's the same with head and neck cancers too, for a different reason. But
yeah.
It's because those are driven typically by HPV and not.
Do you foresee the demise of standard chemotherapy at some point?
Doc Discussions with Dr. Jason Edwards. Brought to you by St. Luke's, St. Louis.
I think that it will be utilized less, but I think we will always use it to some capacity. But the targeted therapy and the immune therapies have really made a lot of headway. And then now you have the emergence of CAR T cell therapy, which is kind of just on the cusp, mainly used in lymphoma, where you used the patient's own T cells to attack the cancer. So there's some exciting, totally new classes of drugs, in the pipeline. And, Mark Fessler here,
right,
super smart guy
and super exciting work,
who's doing some really great clinical trials. He's working with a lot of that, and it's just totally cutting edge stuff. And to be, I'm somewhat familiar with it, but he can certainly speak about that much more intelligently than I can. So you can get to a point where those don't work anymore. The cancer outsmarts it, because you've not only got to kill every cancer cell, but there's different clones of cancer cells. And so you can kill the majority of them or keep the majority of them at bay for a while, but it's hard to take out every one, if somebody has metastatic disease. But I do think that that's the trend will continue, where we utilize those much more than the other medication, the old school chemotherapy drugs, like cisplatin and Taxol and things like that. And the nice thing about that is the targeted therapies and the immunotherapies have much less side effects, typically, compared to the standard chemotherapies. Although they have gotten a lot better at managing the side effects from the standard chemotherapies as well. And so, yeah, I think, hearing about all this kind of stuff, it's daunting, especially with, when you're having breathing issues. Of course, anxiety and breathing issues go hand in hand. If you come in and you can't breathe, you're going to be anxious, I promise. And it's daunting thinking about this, but it's also coupled with some excitement looking into the future that hopefully, especially if they can use AI with research, they can accelerate.
Well, if this new generation of treatment strategies can change prognosis for pancreatic cancer, for glioblastoma, for some of the untouchable cancers that seem not to have a really good response to treatment, that are almost inevitably fatal.
Yeah.
If we can change the conversation in those tumors, that would be awesome.
Yeah. And, something that I haven't seen a lot of, but I think is, maybe on the forefront too, is cancer metabolism, as far as like the things you can do as a person. Or is there an optimal diet that may work with an optimal therapy? I think there's a lot to be kind of learned in that, and that's still pretty wide open. I mean, there's not a ton of recommendations, on that kind of stuff. They thought, does a keto diet help with, and that's not, ready for prime time yet, but, that's another question that can be answered. In fact, I had a patient she was on TPN for another reason, but she had a pretty bad lung cancer, and we treated it, and she kind of did surprisingly well for a long time. And it just, it's a one-of-one situation, so you don't know, but it's like, she's on TPN. Does that have something to do with it or not? I don't know, but it always just made me think, is there something we can do, on the other end? And hopefully with AI analysis of patient outcomes, we can maybe detect some of these trends a little bit better, that would kind of point us in the right way to generate a good hypothesis to test.
Well, AI is going to change things for everybody, including in lung nodule detection, I'm sure.
Yeah.
That we will see a higher yield, and maybe even more accurate diagnosis with the use of AI.
Yeah. Yeah. I think there's plenty of room for excitement, and it's something we should embrace. And so, but, it's good to be skeptical. A good scientist should be skeptical. So we should embrace it with some skepticism, but also embrace it, in aggregate as well. So are there any new things that you see on the horizon with pulmonary care? Any new medications coming out, or?
Well, we have, in the field that I am active in interstitial lung disease, we've had 2 drugs approved in 2014 that are almost identical in effectiveness, both Ofev and Esbriet, And we have a new drug, nerandomilast, which is a brand new antifibrotic drug that just met the criteria for success in the clinical trial. So we'll have a third drug now to start hopefully designing some combination treatment trials to get better results than we are. Right now we're adding 2 or 3 years to the people's lifespans, and we are finding the disease, still inevitably fatal, so we don't have a drug that will stop it, but we hopefully will have combinations of drugs that will stop progression.
Yeah.
We can slow it down, but we can't stop it yet.
Well, it's exciting to see that we're making some headway in that.
We are. So we're getting better in the world. There's a lot of attention in clinical trials for, finding drugs for pulmonary fibrosis, both the idiopathic versions of it as well as the autoimmune versions of fibrotic lung disease.
Yeah.
So we are getting better at managing these patients.
And as you well know, I mean, there's the truth of the matter is there are many ways a person's life can come to an end, and some are much worse than others. And I would think kind of slowly suffocating would be a bad one.
Right.
And so, so that's exciting to see that we're maybe making some progress with some new drugs. And I'm sure there's many other drugs in the pipeline. Some of them will work out and some of them won't in the clinical trials. But hopefully we have an exciting future here in developing some new medications.
And then, there may be new delivery systems, delivering using interventional techniques, chemotherapy to nodules. Whether we have the technology to ensure accuracy and to allow that kind of risk is still debatable, but that's something on the horizon that I think is a goal.
Yeah.
I think, we have robotics, now in interventional pulmonary. Probably the yield is probably a little bit better, than the navigation systems that we use now. But, down the road, whether we can actually use it both to diagnose and to treat, that's a really important question to answer.
And you're talking about actually going down the throat through the trachea and getting to the lung nodule.
That's correct.
And
navigating to that nodule using either robotics, or GPS for the lung, so to speak.
Yeah. And it's tougher than, probably most people would initially think, because you don't get to pick exactly where you go. You have to follow the windpipes.
You have to be following the airway that you're given.
Yeah. The ones that God made for you.
And sometimes things may be behind a wall, and you have to still be able to deliver and to both diagnose and to treat.
And then on top of that, the whole lung is moving up and down, and the nodule's moving up and down.
That's correct.
And so it's some fancy dancing to get there.
Right. And it's usually an hour and a half procedure, whereas a typical bronchoscopy might be 20 minutes. So it does take a lot of time to navigate to these lesions.
Yeah. And I think I may have told you this once before, but Don Busick once said this about you. He said, if you really want to get a good biopsy and get a good piece of it, call Neil Ettinger. And so I thought that was a real compliment.
Well, that was nice of Don to say that.
Well, Neil, thanks so much for not only joining me today, but all of the work that you do with our mutual patients and all the work that you're doing with interstitial lung disease and trying to prolong the length of patients' lives and improve the quality of their lives.
Well, thank you, Jason. And I do want to say that the same goes for you, because when we're making a diagnosis, of lung cancer in somebody, to be able to pick up the phone and know that they're going to be treated with the care you provide them, the emotional support that you give them, and the high quality medicine that you practice with them, that really means a lot to those of us that work with you and take care of these patients.
Oh, thank you, sir. I appreciate it.
Thank you.
Yeah.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.